Okay, thanks, Katie. Thanks for having us. We are just going to jump right in and get started.
All right. Yeah, we're excited to be here. My name is Louis Krolak. I am the behavioral health clinical coordinator at 4th Street Clinic. What that means is I'm a therapist at the clinic multiple days a week, and then I also supervise our case managers and I supervise our therapy students from the University of Utah.
And I am Megan Fry. I'm the behavioral health director. So I oversee all of the therapists, the psychiatric nurse practitioners, and the case managers that work here in the clinic. Go ahead, Louis.
Yeah. So why we're here? The title of our presentation today is Whole Person Care, Innovative Behavioral Health for the Unhoused Community. And essentially, the purpose of this presentation is to shed some light on some of the ways that our clinic has been working on addressing some of the barriers for people who are unhoused and receiving quality behavioral health care. So, the research for homelessness and behavioral health is kind of all over the place, but the most recent research shows that about two-thirds of the homeless individuals have some sort of mental health disorder. And a smaller portion, about 20 to 30% of people, have what's considered severe mental illness. So the distinction there would be the more severe mental illness would look like schizophrenia, something on the psychotic disorder spectrum, bipolar disorders, severe PTSD, severe substance use disorder. And we see all of it. So at our clinic, the most recent research that we have shows that about 96% of the patients that we treat at our clinic are experiencing homelessness. So 4th Street Clinic holds a 330H designation. And what that means is that we're a publicly or a federally funded healthcare center for the homeless program that provides comprehensive medical and behavioral health services to individuals who are experiencing homelessness. So that statistic and that designation mean that we need to do things a little bit differently than a typical healthcare clinic. So we've had to come up with some out of the box, more innovative ways to try to connect with people to get them connected with our behavioral health team. So the presentation today
Jesus.
will we'll talk about our clinic in general. We'll talk about what we do, how we do it. We'll start by looking directly at our behavioral health team, and then we'll move into talking about some of the more innovative approaches, as well as some of our community partners. So before we get started, I was going to ask what, or if anyone is currently working in an integrated care setting. Can't actually see you, so might not get a great answer on that, but that's okay. And then I was going to see how many people are currently working with people who are experiencing homelessness. So that matters because that's going to trail into what we're talking about today.
Yeah, I was going to say, feel free to put it in the chat or you can raise your hand on Zoom if you know how to do that.
Okay. All right, we can head into the agenda.
So Louis covered the agenda a little bit, but just to give you an idea of what you can expect today. We're going to start with a brief overview of the clinic and our history, kind of where we started and what we're up to now. Then we'll talk about behavioral health integration and what that looks like for us at 4th Street. We'll highlight some of our innovative approaches and partnerships that make this work possible. You will hear me say several times today that we couldn't do what we do without the community partnerships that we have in our area. And then we'll also share some encounters or some challenges that we've encountered, because even though this work is extremely rewarding, it's not always easy, as I'm sure you all know. And then we'll wrap up with a few practical takeaways.
Okay, so I'll give you a broad overview of 4th Street Clinic in general. So for context, this is a picture of our clinic. We are located in downtown Salt Lake City. We're in a very busy area. There's a lot of foot traffic all around our building. If you look at that picture where that tree's at, that is our front door. And if you show up early in the morning, if you drive past the clinic before we're open, there's going to be a line all the way down the street of people waiting to receive our services. So we are very busy. We have a lot of patients, and we're able to do a lot of very meaningful work within our walls. So first we'll talk about who we are, then we'll talk about our patients, and then we'll get into all of the services that we provide at our clinic.
So this is just a quick overview of the clinic. As it says here, our mission statement, 4th Street Clinic helps individuals experiencing homelessness improve their health and quality of life by providing high quality integrated health care. We really want to be the medical home for our patients. We really want them to feel safe here and come for their primary care, their behavioral health, their dental care, and so on. We'll get into more details of all those services in a bit. So in 1988, we opened as a single room clinic in the local homeless shelter. At the time, Salt Lake City just had one shelter, and it was run by one volunteer provider and one volunteer nurse. I think it just started a day or two a week, and then eventually grew from there. In 1993, we moved into our current location, which has become our permanent setting. In 2001, our pharmacy opened. Our pharmacy fills on average 450 prescriptions per day. And for a clinic our size, we have 2 pharmacists, to give you an idea. So that's a lot of meds that they're filling every day. In 2014, our dental clinic opened. Our dental clinic is beautiful. It's the newest part of our building, so the rest of us are a little jealous at how nice it is in there. But it's a 4-chair clinic, and it's really nice. In 2019, our mobile unit launched, and we'll go into more detail about the mobile unit and the services that we provide there. In 2020, due to the pandemic, all patient services were moved into tents in the parking lot. And if you know anything about Salt Lake City and our winters, they're certainly less harsh than some of you, but they can definitely be rough. And so to provide all of our services for nearly 2 years in our parking lot was, we'll say, challenging. And then in 2021, we began the process to become fully integrated with, as far as behavioral health goes. And we will get into much more detail about what that looks like and looked like as we grew. Here's a snapshot of our patients who we served in calendar year 2024. We provided healthcare to 6,606 unique patients, which was 30,384 patient visits. And that included here in the clinic as well as all of our outreach locations. 96% of our patients, like Louis mentioned, were experiencing homelessness. And just to clarify, that means it does mean on the street, but it also means in a temporary shelter or couch surfing in their car and so on. 42% of our patients had Medicaid and 14% had private insurance or Medicare. And then 44% were uninsured or self-pay. Some of the common health conditions that we face are, I actually talked to our medical director about this question, and he said, he gave me this answer: diabetes, hypertension, and substance use disorders. But he said, we really, although our population looks different, we really treat the same kind of things that any primary care office is going to treat. So if you ask any primary care provider, they're probably going to answer similarly as far as that question goes. And then our BH conditions, our common BH conditions, also substance use disorders. Both teams provide care for substance use disorders. PTSD and bipolar, we do see a lot of psychosis and psychotic disorders, but these are some of our most common.
Okay, so our services on the left side of the screen are going to be the services that we provide in our main clinic. And then on the right side of the screen is all of our outreach services. I'll introduce all of these, but I'll speak more about the outreach services later on in the presentation. So this is what we do, and we do a lot. Some days it feels like we do too much. These are obviously individual departments, but we all work together very closely as a unit. We are very much an integrated care setting. And most of the time when people come into the clinic for one of our services, they're going to receive a number of other services as well, because we're really trying to get as much work as we possibly can with them done, because we don't know when the next time we might see them is, and they're just very complex in general. So I like to say that we are integrated care at its finest. We're basically like the Avengers of healthcare. All of that is really important because there's so much need that comes through our front door. So we know that our patients have complex histories. We know that their ability to follow up is not always great. So when someone's in the clinic, they might be in the clinic every day for 3 weeks and they seem to not want to leave. Other times we won't see them for a year. So we really try to operate as if, we need to strike while the iron's hot. We need to get as much done as we can, because we might not see them for quite some time. So to go through each one of our services, when it comes to primary care, we have a mixture of doctors, nurse practitioners, physician's assistants, and on any given day, we're going to see about half of them in the clinic, and then half of them are spread out throughout the community at all of our outreach sites. For our behavioral health team, we're comprised of psychiatric nurse practitioners, therapists, and case managers. For our dental team, like Megan said, we are a full service dental clinic. We do pretty much anything but implants. So we do dentures, crowns, fillings, extractions. And on a normal day, our dentist will see between 12 and 14 patients. And our hygienist will also see from 8 to 10 patients. One thing to highlight for our dental program is we do a Monday morning motivator. It's kind of like a program that comes out every Monday. We celebrate patient success stories. We talk about what's going on in the clinic. And during my time here, the ones that really get me the most emotional are going to be the dental stories. When you talk with patients, we naturally think they have these severe medical issues, severe behavioral health concerns, but in talking to patients, they are so openly gracious about how important their dental care is and how much confidence it gives them and how important it is to their health. And we do these side-by-side photos when someone gets dentures, not all the time, but every once in a while we'll spotlight someone. And seeing that transformation is it's really powerful. So the work that our dental team's doing is absolutely incredible. Moving down into pharmacy, Megan talked about that one as well. I think it's important to highlight that we are a small little clinic. On average, they're doing between 400 and 500 prescriptions per day. But back in June, their record is 763 prescriptions in one day. So if anyone is an actual superhero at our clinic, it is the pharmacy team. They are filling so many prescriptions. They are meeting so many needs. So that's just a really great resource that we have. In addition to that, we have specialty care clinics that come in. So that is going to be teams of people. It's split down the middle between volunteer providers who come in and donate their time. Sometimes they're retired providers, or they could be students from the University of Utah coming in for their rotations with us. So the specialty clinics that we offer are gynecology, dermatology, optometry, audiology, ophthalmology, orthopedics, podiatry, neurology, and we're currently in discussions to get rheumatology in as well. So great resources that we have there. For our ancillary services, we have a case management team, both at outreach and in the clinic. Our case managers are helping pretty much every other team around the clinic connect people to resources, build rapport just so that we can help people with the next steps and whatever their journey might be. So they're very busy as well. We have referral coordinators. They also are doing a ton of work. They do between 500 and 600 referrals per month. And lastly, we have a eligibility and enrollment team. So those individuals are going to help patients get connected to insurance and make sure that everyone who is eligible is enrolled in Medicaid. And switching gears over to our outreach teams, I'll briefly introduce these, but I'll get into these a little bit deeper later on. We have a street medicine team, mobile clinic. We have case managers at all of the homeless resource centers, the shelters around town. We have a location that is considered a medical shelter that is called the MVP. And then we also have behavioral health in supportive or permanent supportive housing called Magnolia. So moving into behavioral health integration, here we're just going to introduce our behavioral health team, and we're going to talk about how our behavioral health team is integrated throughout the rest of the clinic. So beautiful picture of our team here. Just to introduce these people, we have 2 psychiatric nurse practitioners who are going to focus on medication management. We have 4 case managers. 1 of them is at an outreach location. 3 of them are in clinic. We currently have 6 therapists, same thing, spread out. Some are in clinic, other ones are at our outreach locations. We currently have 2 MSW students from the University of Utah who conduct psychotherapy and help with assessments and some of the roles within the clinic. We have 1 psychiatric nurse practitioner student. And then the last one on here is the behavioral health clinical coordinator. That is myself. See patients a few days a week, and I supervise our case managers and our students. Conveniently, Megan, our fearless leader, left herself off of this slide. She should be at the very top. She's our behavioral health director, and she also sees patients 2 days a week and then takes care of the rest of the team.
Thanks, Chloe. Okay, so I'm going to talk a little bit about how behavioral health is actually integrated into other parts of the clinic. So warm handoffs are a big part of our model. A patient might come in to see their PCP and happen to mention to their doctor that they're feeling overwhelmed or struggling with some anxiety, or the PCP notices some symptoms, maybe of psychosis or other things. The provider then reaches out to the behavioral health consultant or the BHC. So if it's me, if I'm the BHC that day, I will go see that patient in the same exam room where they met their medical provider. And I'll just check in with them. BHC visits are generally fairly brief. I'll just check in with them about what kind of support or coping skills I can offer in this moment, and then also talk about the other behavioral health services that we offer in the clinic and talk to them about whether they're interested in any of those services beyond this brief visit. So sometimes that results in scheduling a therapy appointment or getting them scheduled with one of our psychiatric nurse practitioners for ongoing care, or we might call in a case manager to help with a bus pass or a voucher for their ID or whatever they might need. Warm handoffs also go the other way. So if I'm meeting with a patient who appears medically unwell, I'll ask if they'd like to see a PCP, and then I'll get them on the list to see a provider. And we also coordinate warm handoffs with case managers, which I briefly mentioned, referral coordinators, dental pharmacy, and even the enrollment specialists. Sometimes when a patient is here, they think that they're coming in just to see their medical provider for whatever issue, and at some point, you might have the BHC and an enrollment specialist and a case manager, for example, all sort of hovering around the door to see who's going to go in next and talk with this patient. So we really do, like Louis said, try to get as many services completed in one visit as we can, in case we don't see them again. We also do shared care planning. So we have real-time consultations. So if I'm the BHC and they call, a provider calls me in to meet with a patient, I'm going to go talk to that provider first and just get some background from them about what does this patient need? Are they looking for support right now? Do they want to come in later? And I'll just check in with that provider, and then I'll go see the patient. And after I finish with the patient, I'll go back to the provider and give them an update about how that conversation went. Do they want to come back for therapy, for example? Beyond that, we have a monthly provider meeting, which includes all of the behavioral health providers, so the therapists and the nurse practitioners, as well as all of the medical providers. And we will consult on cases, we'll offer support, just communicate about how things are flowing in the clinic, things like that. We rely heavily on screening tools and workflows. Every patient who completes a medical or BH visit fills out a PHQ-9. Often it's the MA who is doing that with them. Elevated scores will then prompt a visit. If it's a primary care visit, an elevated score will then prompt a visit from the BHC. So that's one of the things that would have the primary care provider reach out to us to come in and check in with that patient. Patients who are in ongoing regular weekly therapy complete a GAD-7 at least monthly, and those things just help us track progress and identify when they might need a higher level of support. The street medicine and mobile team, I think we're going to go into more detail in this, but we do have a full-time therapist on our mobile bus who is there to offer support to the provider who's on the bus that day, and also other folks who are in the shelters or wherever the bus landed that day. And then we have a therapist who spends half of her time here in the clinic and half of her time with the street team. So we do provide behavioral health support therapy on the street. And then our psychiatric nurse practitioners are also on the mobile team. Not every day, but they go out about every 2 weeks at certain locations that tend to have higher need patients at those locations. We just wanted to share a story about this family. We're going to call them the Jensen family. And this family is a mother and father and 2 elementary aged children. And we first found them through another outreach team from another provider. Sorry, I need to take a drink. From another community partner, and they reached out to us because this family needed some medical support. And they were living in a trailer at the time that we started working with them, which was about 3 years ago. And when we first started working with them, the father was experiencing severe psychosis. He was struggling to trust anybody, really. He was experiencing a lot of paranoia. The mother was working really hard to keep the kids happy and healthy and going to school every day, despite their homelessness and dad being pretty unwell at that time. So our street team started working with them and eventually built up enough rapport, mostly through the kids, because the kids really kind of connected to one of our street team members at the time. And then once they saw how well the kids were treated and that they would show back up every week with some supplies, and sometimes that's all that they did. They didn't provide any medical care sometimes because the family was hesitant. But over time, they built up quite a rapport with the street team. And then they eventually asked one of our psychiatric nurse practitioners to go out with the street team to meet with this family. And so he went out with them one day, and although they were hesitant, both parents did meet with him, and he started mom on some antidepressants and started dad on some antipsychotic medications. Shortly after that, they both started to feel much better. Almost all of the father's symptoms subsided, and he was able to eventually go back to work. And mom eventually went back to work as well. And at this point, about 3 years later, both parents are full-time employed. They have now been housed, and both kids were going to school, but they're consistently going to school now. And it's one of my favorite stories because it shows our partnership with the other organization that first introduced us to this family, but also how well our street team and our behavioral health team worked together to provide care for this family. And this family still meets with our psychiatric nurse practitioner. They now trust enough to come into the clinic for care, so they will come into the clinic, and so they're getting their primary care and their behavioral health care from here. So just one of my favorite stories.
So moving into some of the innovative stuff that we're doing and some of the partnerships that we're currently working with. So as far as innovative approaches, I'll talk to you about medication-assisted therapy in primary care and behavioral health, our walk-in behavioral health availability, as well as all of our outreach behavioral health services. So overall, with the medication-assisted therapy, we know that MAT is one of the most effective evidence-based treatments for substance use disorders, especially opioid use disorder, and is generally accepted as the gold standard for treatment of addiction currently. So we know that MAT works, and we know that it reduces overall overdose rates. It cuts relapse rates in half. It helps people to stay in treatment longer, and just overall increases stability. And for a lot of our patients, getting on the medication is the first step. But sometimes trying to get people on medications can come with all sorts of barriers. So in our clinic, we do our best to eliminate those obstacles. So at 4th Street, we offer a low barrier, high quality approach to getting on medication-assisted therapy. So patients to do that can either be seen by primary care or a behavioral health provider. And they can do that through scheduled visits, or they can do that just using a walk-in visit. When someone's ready to address their addiction and get help, we can do that essentially immediately. All we need from them is a urine test, and even if that test is positive, that does not disqualify them. The provider will essentially do an assessment and identify what their needs are. And when they come in for the first time to get on medication-assisted therapy, patients are required to come back in 1 week so the provider can have eyes on them, to be monitoring them closely. And from there, the provider will decide what kind of additional support they need. One thing with that, we see a lot of people who come straight from prison, people who were in jail for whatever amount of time. And when they get out, the first stop is frequently 4th Street Clinic. We want to get them connected as soon as possible. We want to get them stable and make sure that they have the support that they need. And having this low barrier approach really allows us to do that without jumping through any of the obstacles. So in addition to that, every time somebody comes in for medication-assisted therapy, we're going to double up on care, meaning we're going to have a therapist step in and introduce themselves and offer up some additional support as well. So there's a lot of cases that are very complex. And if the patient is too complex, if they have comorbidity with other mental health disorders, we have a very easy transition into having someone see primary care, and we can get them straight over to our behavioral health providers. So we do our best to offer wraparound services. And part of that is our ability to have the walk-in behavioral health availability. So really all of our services can be done via walk-ins. When people call to schedule other places, it can be really difficult. A lot of people don't want to wait 2 months for an appointment. All of our services at the clinic can be used via walk-ins, but with our behavioral health approaches, it makes it even more important that people don't have to wait. So that can be for medication or that can be for therapy. And like Megan talked about before, we have a BHC position. And what the BHC is, it's a behavioral health consultation. We have one therapist each day who that is their designated job. That is what they do so that they can make sure that anyone who walks in isn't going to wait long. But the job of the BHC is threefold. So the first thing is that they're going to talk to everyone who comes in who is a new patient to the clinic. So after a provider sees them, they have a designation of NPV, which is a new patient visit. And the BHC therapist is going to go in there just to briefly introduce themselves, to talk about our services and just offer up additional support in case somebody needs it. And sometimes they're not interested. Sometimes they don't want to be talked to. They're here for something else, and that's totally fine. But a lot of times we're just planting that seed, letting people know, hey, if anything comes up in the future, we have walk-in therapy options. We have the support from psychiatric nurse practitioners. We have case managers. If you need something in the future, just walk in and come and talk to us. So in addition to that, the second thing is that we have the walk-ins. People can just get immediate support, not something that they have to wait long for. And the third thing that the BHC therapist does is going to be take on any provider referrals. So whether on our outreach team or in our main clinic, if somebody sees a provider, they score high on a PHQ-9. If they break down during the visit and start talking about some other issues they're having, the provider will make that referral in the system and we'll get a therapist in there. So all of these options are very valuable for our team because we can offer support for people right away. So in addition to that, we'll change the slide and I'll move into what we're doing for our outreach services. So first one here is our outreach street team. This team consists of one medical provider, one case manager, an EMT, and as of last year, we added a therapist to that team as well. So our therapists work out with the street team is very collaborative with the provider and with the case manager. What their role focuses on is really going out there to build trust and rapport. They're able to provide on-the-spot counseling. They can conduct assessments for mental health needs, and then they can connect people to resources. So the way that the therapist out there describes it is we shower people with material support while offering them with emotional support options. And essentially, they need to build that rapport first. And once someone builds rapport with someone out on the street, that increases their likelihood of them being able to come to the main clinic to get all of the services that we have to offer there. So if anyone is interested in medication-assisted therapy, if they're interested in any other appointments, our therapist can step in there and help with that. Moving into our mobile outreach clinic. Our mobile bus is a 45-foot mobile clinic. On the mobile clinic has medical providers, medical assistants, and recently we've added a mental health therapist to that. The mobile clinic goes to all of the homeless resource centers, which are the local shelters. And the therapist there acts as essentially the BHC on the bus. So she's there to be able to provide support if anybody needs it. She also helps to connect people back to the main clinic. A lot of her job is building rapport with patients who are in the shelters, who may or may not have that trusting relationship with the main clinic, doesn't feel comfortable getting their needs met. And the therapist there will either take referrals from the case managers or from the providers, and she's able to provide support for them on the spot. So it's another way that our therapists are getting out into the community to meet people where they're at, to provide support to people who otherwise may not be willing to come into the main clinic. The next one is, we call this the MVP. The MVP stands for medically vulnerable people. And this is a shelter that provides interim housing and medical services to seniors, veterans, and the medically frail who are experiencing homelessness. So the MVP it's a non-congregate shelter, so you can't just walk up. People can only get access through referrals from a community partner or through the clinic. It accommodates 165 people, and it is an old Econo Lodge motel that they've renovated and built specifically for this reason. So throughout COVID, we observed that there's a significant number of aging people who are homeless, people with health needs and things that just aren't being met. So this shelter was built. This goes along with our collaborations with our community partners as well, because that's essentially what this is. The building is owned by Shelter the Homeless, but it's operated by an organization called the Road Home. So they focus on the operation side of things, and they have case managers. And then 4th Street comes in with the medical and behavioral health support. And the goal for this shelter is really just to stabilize the health for individuals while they connect to housing. And the last one of our outreach that we'll talk about is the Magnolia Apartments. Magnolia is considered permanent and supportive housing. This is a complex that has 65 units and is part of our health and housing transition program. This building was built in 2021, and we added a therapist there in 2023. So this building was specifically built for people who are chronically homeless. So 99% of the tenants who live here have they've previously been evicted from at least one other housing program. And they have strained relationships with community partners. A lot of them have been barred from using community resources due to their behavior, due to substance use. So the goal of Magnolia Apartments was to provide a stable housing option for people. And then when they're housed, they have that stability, and then we can insert in our behavioral health team and provide support that way. So in addition to our therapist, we also have a psychiatrist on site there through the Huntsman Mental Health Institute. She's there 1 day a week. She is helping with medication management. Our therapist and our case manager can schedule appointments with our psychiatrist, and we can address a lot of the larger issues. So one of the main things they've been doing recently is we're currently doing long-acting injectable medications there, which research shows dramatically increases adherence and it increases stability. So there's a massive need at Magnolia Apartments, and we're inserting our behavioral health team in there to make sure that there's the appropriate support there for people who truly need it, who are very vulnerable, and who typically don't do well in other settings.
Okay, you've heard us both talk about the community partnerships that we have. I'm noticing the time, so I'm going to kind of speed through this section a little bit, but please let us know if you have questions. So one of our biggest community partnerships is with housing providers. We specialize in whole person health care, not housing. So we rely on the housing providers and case managers because they're experts in their field. Many of our patients begin their path to better health once they become housed. We are also great partners with the shelter providers in the area. Louis talked about how the mobile bus goes to the shelters. We also have EMTs embedded in the shelters because there were so many calls to EMS from the shelters happening, and you can imagine how expensive that is. And so we put EMTs in to help assess, does this really require a call to EMS, or is this something that we can take care of here, or something that we can send you in a cab to the hospital to be checked out? So that is really, really cut back on those calls. Let's see. Our outreach teams work really closely with other outreach teams in the community. So other community partners also have outreach teams. They're just not medical outreach teams. So they may come across somebody and they're providing supplies or helping apply for housing or something, and realize that this person needs some medical care. So they will then call our street team, who will go find this person. And of course, it goes the other way too. We will often work with somebody for their medical needs or their behavioral health needs, and then that person starts asking about housing. And so we will call in one of the other community partners to help with that. As you can imagine, we work closely with local hospitals. We even share an electronic health record with one of the major hospital systems, which makes it very easy for us to communicate with those providers. If we send somebody to the hospital, we can then check in their chart to see, was this person admitted or how are they doing? We coordinate with emergency departments, of course. And Louis mentioned Huntsman Mental Health Institute. They recently opened a crisis care center, which is effectively an emergency department only for mental health issues. So somebody can show up there at 24 hours a day because they're feeling suicidal, or their family member is having a psychotic event, or they're just feeling like they're having, an anxiety attack or whatever. They can show up there and get assessed and get help and get support and sent to a higher level of care if that's necessary. That has been a really wonderful partnership.
And one other thing on here is the homeless court. I'll be brief with this. We've built a relationship with the homeless court liaison in the community. She's come in and she's talked to multiple of our teams, our providers, our case managers, because court issues and legal troubles are a massive barrier for a lot of our patients. Even if they do get to a point where they want to work on stability, if they have warrants, they're going to struggle to get into housing. They're going to struggle getting employment. So we work closely with the homeless court. We send people weekly to the court that they set up in the community. And it's just a really good resource that we have. That's really important that we strengthen that relationship all the time because our patients really need it.
I was going to tell you another patient story, but I know we're getting short on time, so we'll come back to that if we have time. So now the fun part is talking about challenges and some things that we've learned along the way. Staffing, like many nonprofits, it's hard for us to offer a competitive wage. I think that we're pretty competitive among other nonprofits in the area, but compared to, say, a private practice where a therapist could also go work, we really can't meet those wage needs. Also, our patients carry significant trauma, and supporting them is emotionally draining and heavy. Secondary trauma and burnout are very real issues, as I'm sure they are for many of you. We're preparing for Medicaid cuts next year, or almost next year. Grant applications and reporting can be cumbersome and time sensitive, and sustaining services while funding fluctuates is just a challenge that we talk about all the time. Patient mistrust. This population has a hard time trusting people. They have often been treated like they're less than by other providers in the community. There's a lot of trauma just from being unhoused, and many of them have experienced trauma previous to being unhoused. So it's hard to build. It can be difficult to build up those relationships. But we work really intentionally to build rapport. We work from a trauma-informed lens. We get at least annual training on trauma-informed care so that everybody, our providers, our front desk staff, everybody is trained on that. And then I think the biggest growing pain that I want to talk about really quick regarding integration is that some of the primary care providers were used to functioning pretty independently when we started doing more integrated care. They weren't familiar with what behavioral health teams could offer. They're just used to doing it all themselves. And so over time and with strong leadership support, we've built a shared understanding. And today, behavioral health is fully embraced as part of our culture, and providers see the value not only in the services that we offer our patients, but the stuff that we can take off of their plates, because now they can really concentrate on those physical health issues and then pass that patient off to us so that we can work with them on their mental health concerns.
So what have we learned with our experience in working with this population? All the time, we've learned that trauma-informed matters. Trauma-informed must be our first line of defense. We have to see things through that lens. It's important to be trauma-informed with the patients that we're working with, because trauma is both a cause of homelessness and a consequence of homelessness. And if we don't go in with a trauma-informed lens, we can unintentionally trigger our patients or re-traumatize them by how we react to some of the things that they are doing or some of the ways that they are behaving. And ultimately, if we aren't trauma informed, we could lead a patient to leaving the clinic one day and not coming back to get the care that they need and that they deserve. Next, flexibility is key. We have to meet the patients where they're at. And that's literally and figuratively. We need to go out and find them if they are in encampments, if they are outside of the reach of our normal clinics. So we have our street team and mobile out there doing that. And also we need to be flexible with how we respond to things. So with our population, one size fits all approaches just don't work all the time. We have to be able to be flexible, and that's going to get us to a point where we're able to do the positive work that we know that we need to with them. Next one, trust takes time. For many of our patients, trust is not given. Trust needs to be earned, and it needs to be earned slowly. Our patients historically have likely been let down by people, by systems, by institutions, all who have made a promise to help them. So we are oftentimes starting at a disadvantage, and we need to show up consistently and non-judgmentally and compassionately with our patients. So we send the message to them that we do care how they feel, and we do feel like they can be safe here. And ultimately, that is the foundation for us to really produce growth with them, is making them feel like they're comfortable and they can come here and they can trust us, so that we truly can do that impactful work. And the last one, as we've highlighted throughout this entire presentation, is the importance of collaboration. Homelessness is never caused by just one issue, and it's not going to be solved by just one agency. So we as a team need to rely on each other within our clinic, but also we need to collaborate out in the community and show up for our patients in whatever ways that we can. But we can't do it alone. So we will always be focused on that importance of collaboration.
Okay, just a few key takeaways that we hope you take with you as we wrap up today. Whole person care matters. The mind and body are connected, and our patients do the best when we address both. Integration is essential for high need populations. Many patients lack transportation or childcare, and they have an understandable mistrust of the systems that Louis and I have both talked about. We may see them tomorrow, or we may not see them for another year. So every visit is an opportunity to provide as many services as we can. And then partnerships expand impact. We've talked about how critical partnerships are, and strong collaborations help us reach more patients in more places and with better continuity. That's all she wrote. Anybody have questions for us?
Great, thank you so much, Megan and Louie. Yeah, we do have about 6 minutes left, so if anyone has any questions, feel free to come off mute, or you can put them down in the chat. One quick question that I had was, I really enjoyed like all the partnerships that you guys highlighted. I wanted to ask if there are any kind of additional areas that you've been looking to grow in, and like any potential partnerships that you've been trying to work on.
I think one thing that Louis has been working hard with on with his case management team is better partnerships with now I just forgot what they're called, skilled nursing facilities, because we have a lot of patients who need that level of care for some period of time. So that is one that Louis has been working hard on improving. I think we're always working on our partnerships. We have good partnerships already with the shelter providers, but I think we're always working on making those even stronger, possibly, moving behavioral health into the shelters and different things. So that's one thing that we have talked about. And we are going to the team that Louis talked about in the Magnolia that currently has a therapist and a case manager and the psychiatrist. We will be expanding that into another permanent supportive housing location. So we're really excited about that.